Could you please explain how to manage subserosal fibroids?
Yes, so generally, if we can, we try to ignore subserosal fibroids because they do not impact IVF significantly unless they're very big. If subserosal fibroids are very big, let us say 10, 15 centimeters, so then those fibroids can push uterus up and reduce the access to the ovaries. You may not be able to see ovaries easily because they may go shadowing and your scan beam may not be able to penetrate through the fibroid and see the ovaries. So, and also they can push ovaries so high up, uterus high up and ovaries so high up that may make it difficult to access during egg collection. But unless they cause a problem with access, we do not treat subserosal fibroids. So because the treatment of subserosal fibroids involves surgery, which is we call myomectomy, removal of the surgery, and that treatment can cause more problem than solution. Why? Because invariably when you have a myomectomy, you have a pelvic adhesions. So typically after myomectomy, you develop a lot of scar tissue, and that scar tissue can cause scarring of ovary and push ovary very high up into the abdomen. It may make it even more difficult to access the ovaries. So this is why if we can, we don't do any treatment for subserosal fibroids. And then if the fibroids really causing like pain, for example, sometimes pedunculated fibroids can get torted, and that if it causes pain, then it may need to be managed. But otherwise, we don't just ignore subserosal fibroids in IVF setting.
Thank you, Dr. Rusty. And could you please explain how to manage intramural fibroids?
Okay, so intramural fibroids. The intramural means the fibroid sitting in the wall. Let us say if you imagine the uterus as a room, in the wall, right in the middle of the wall, you have got fibroid. So it really, the management of intramural fibroid depends on size of those fibroids, first, and second, the location of those fibroids, and the third, also depends how many fibroids you have, number of fibroids you have. So size, location, and number of fibroids you have. So if you have few smaller fibroids, like 3-4 centimeter fibroids, you don't need to do anything. They don't really impact your IVF treatment. So if you have large fibroids, especially if they're causing distortion of uterine cavity, then you may need to deal with them. Really, when we do IVF, we do not want distortion of endometrial cavity. Why? Because distortion can reduce the chance of implantation. When your endometrium is distorted, the drainage of endometrium gets impaired, so which means you may have a fluid collection. Let us say you have got fibroid so big and the cavity is not collapsed. So you have 2-3 big intramural fibroids, and inside the uterus is not smooth. It's just so distorted. You have an impairment of drainage of the uterus. So inside the uterus, you keep producing fluid all the time, and that fluid needs to get drained out and also needs to get absorbed. Because of anatomy of the cavity is distorted, and that fluid can get collected. When you transfer the embryo, that fluid can be toxic to the embryo. So we don't want any distortion of the cavity. If intramural fibroids are really distorting the cavity, yes, they may need to be removed, or they need to be treated, or you need to use a generic analog like Zoladex for 6 months or so to reduce their size so that the distortion will disappear. So essentially, also your size and the number of the fibroids is determined. If you have lots of large fibroids, then of course it can push uterus so high up. It will be difficult to see ovaries on a transvaginal scan to monitor your ovaries during stimulation, and also it can be difficult to access ovaries for egg collection. So if that's the case, then you may need to treat intramural fibroids by doing myomectomy surgically or using Zoladex to shrink the size of those fibroids.